Yeah, so thank you so much for having me. I'm excited for an opportunity to talk a little bit about trauma-informed care, kind of an approach to clinical care, and just to navigating life with chronic and complex illnesses. So to introduce myself briefly, yes, I am a pediatric psychologist. I'm at the University of Alabama at Birmingham, but I practice at Children's of Alabama with a group of neurosurgeons in kind of an integrated model of psychology embedded in neurosurgical care. And our goal with this model is kind of to support the psychological and physical needs of our patients and their families, and really minimize the impact of medical care on psychological outcomes through a trauma-informed practice. So yes, there's lots of talk about the comorbidities of medical and mental health, but it's important to us that we recognize that just by virtue of engagement with us as providers, that adds a layer of stress and impact on mental health. So that is exactly kind of what I want to talk about today. I really want to focus on, yes, some of the psychological and mental health needs that are commonly experienced in, EDS, that clinical population, but with a focus on those needs through a trauma-informed lens, and really how we can use that framework to inform how we navigate the medical system and trauma-informed care models. So this is beautifully covered already, but just to loop back, just briefly review, like many of you know, psychiatric comorbidities are really common in this clinical community. Research has shown that up to 69% of people with EDS have clinically significant anxiety, either now or in the past, and up to 75% have clinically significant symptoms of depression, at least at some point. So there's also several studies that highlight psychological distress kind of outside the context of the DSM criteria or a diagnosed disorder. So they note prevalence rates of things like disordered eating, self-harm, suicidal behaviors that certainly exceed those rates seen in the general population. We also know that up to 34% of people with EDS have diagnosed PTSD or post-traumatic stress disorder, with studies suggesting that even when the diagnostic criteria for PTSD aren't met, this clinical population also has significant symptoms of post-traumatic stress that interfere with their daily life, their ability to navigate the challenges of chronic illness and pain, even without the diagnostic label. So we know, of course, it's essential to consider psychological disorders, these comorbidities and the prevalence rates for several reasons. First, we have to maintain that awareness for all the reasons that have been discussed. Awareness on the part of the providers and the patients, really because that awareness also then supports the importance of including mental health providers as integral parts of the multidisciplinary teams. But this is where I hope to kind of build on some of the things that have been discussed. I think it's really important to broaden the conversation around this topic to include more of the context for mental health concerns in chronic illness and pain, because without that context, it can be really easy to slip into the rhetoric or the narrative, or perpetuate the narrative that it's psychological or real. Is this their anxiety or is it a real symptom? And we know that narrative has is not only inaccurate, again for the reasons that were just so beautifully listed, but it's also unhelpful and potentially harmful. So at this point, of course, we know enough about the mind-body connection. It is far too strong for that to be a meaningful narrative anyway. But it also potentially minimizes the role of engagement in the healthcare on mental health and kind of our burden as a healthcare system and as providers to mitigate some of that, the impact of what we do on mental health outcomes. So specifically, many chronic illnesses, chronic pain conditions, and specifically in EDS, those patients tend to have higher rates of trauma exposure, even before diagnosis, kind of at baseline, and higher rates of mental health concerns. These things are known to increase the risk of developing chronic pain and illness, kind of a predisposing factor. And then in turn, these, the chronic illness, the chronic pain, tend to then themselves beget more stress, beget more trauma exposure, which leads ultimately to poor health outcomes. So ultimately, it's a pretty vicious cycle that is experienced by far too many people with EDS and similar conditions. So instead of kind of the traditional conversation that I feel like is focused on this aspect of things, they have mental health concerns, problems, there's a trauma background. I really would like to broaden the conversation to focus on and include how we can interrupt or at least minimize the cycle by focusing on the impact of healthcare on these outcomes. So the need for this shift in the conversation and kind of our awareness of this is unfortunately abundantly evident in research that's been conducted simply to highlight and emphasize the lived experience of people with EDS. So a study in 2023 showed that a whopping 96% of these patients experience the healthcare system itself as an antagonistic force, as not only not designed to meet their needs, but also an active barrier. And then that same study, I found that 85% of 86% of EDS patients reported at least one kind of distinct informative encounter with a clinician that had a really strong negative impact on them mentally, personally, and just in terms of their ability to engage in the healthcare system. So while, hopefully there will be a little bit of a bottom-up approach that providers and kind of how we engage in trauma-informed practice ultimately will have a positive impact on the healthcare system as a whole, I feel like it certainly makes sense for us to start here. So the most common source of distress and traumatic stress reported by people with EDS and really many other chronic illness, chronic pain patients occur within the provider and patient relationship, which Halverson and colleagues define as kind of clinician-associated trauma. So what their research suggests is that a significant majority of patients have felt invalidated and generally just disrespected and treated unprofessionally in at least one encounter. Many reported that they feel like a provider has acted punitively towards them. So for example, the provider may have taken, or at least it was perceived that they had taken steps to actively prevent them from seeking a different treatment course or seeking a second opinion, or either referring them out because they felt like it was too difficult. And unfortunately, in the latter of those instances, a significant majority also perceived that referral, which was probably one of many, as a form of abandonment by the providers. So certainly ample breeding ground for really challenging interactions that can lead to this clinician-associated traumatization. And collectively, these experiences often lead patients to kind of a growing sense of self-doubt, to lose trust in themselves, lose trust in the healthcare system, and they have identified that these experiences, aside from other things they may be experiencing in other aspects of their life or a background of other mental health concerns or needs, they experience this acute psychological distress related to these these experiences with healthcare. That in turn tends to lead to avoidance of healthcare and ultimately worsens mental and physical health outcomes. So certainly these experiences are concerning from ethical perspectives and from the mental well-being, for the mental well-being of patients, but also even from a medical perspective, because the documented outcomes of clinician-associated trauma include worse physical health outcomes. So even when these experiences don't rise to the level of clinician-associated trauma, research and abundant theory have shown that being in what's termed invalidating environments generally have similar outcomes. So we define invalidating environments as really having two characteristics. So the first is that they send the message that somebody is wrong in their description and analysis of their own lived experience. And the second is that it sends the message that their emotional response or emotional responses are invalid and really kind of attributable to undesirable personality traits, or that's just how they are and we don't like it, instead of a valid response to an event. So with that said, the research on the outcomes of invalidating environments overlap very strongly with the outcomes that have been documented by clinician-associated trauma. So again, negative beliefs about oneself, the healthcare system, and then the potential to become very avoidant. So it is also associated with greater prevalence or increased psychiatric comorbidity. So again, it still elicits at least a subclinical trauma response potentially, and worse mental health outcomes. So with that, again, I kind of highlight the fact that we simply can't have a conversation around psychological disorders and EDS without talking about trauma-informed care. So trauma-informed care is generally understood by most models to have 5 core kind of components or tenets. So safety, which involves protecting everyone's physical and emotional safety and well-being. Trustworthiness, which is considered to come from transparency, clear expectations, clear and consistent boundaries within the patient-provider relationship. Choice, or supporting a patient's autonomy within the healthcare system. Collaboration, or the idea of working with and not for or upon or to our patients. And then empowerment. So in every step of the way, really building a sense of hope, possibility, and an element of I'm in control of at least some of these aspects. So you can see kind of in the infographic down here that there are specific practices that support these tenets, and hopefully with these becoming increasingly the norm in healthcare, hopefully they will increasingly become the norm and be part of patients' experience as we continue to emphasize training, education in these ways of practice. But I don't want to spend too much time on those practices because those are the responsibility of providers. And in general, I want to be very clear that the burden, the onus of engaging in trauma-informed care is not on the patients. It is not your responsibility, but kind of through a lens of empowerment, there are ways that we as patients can engage in our own health care that supports and recognizes this trauma-informed component. So what I'd like to do then is spend a few minutes kind of talking through the ways that we can, again, facilitate our own trauma-informed care in each of those 5 tenets. So the first tenet, of course, is safety. So what are some actionable things that we can do to feel safe? regardless of how an appointment goes, regardless of what an interaction looks like, that we leave or we enter with a feeling of safety. And really in a way that perhaps even ensures kind of the best outcomes of the interaction itself, because we go in grounded and secure. So not to be totally cliche, but truly grounding and intentional relaxation can be a game changer, because our bodies learn very quickly when to be on guard, especially when we've experienced invalidating environments, especially in the context of chronic illness and chronic pain. It is important that we intentionally remind our bodies that we're safe, we're in control, at least of some aspects. And this, this is the here and now. I'm grounded, I'm alert to my senses. I often encourage patients to do progressive muscle relaxations in the waiting room. So what else are you going to do? Really just reminding our bodies that they're safe, even when that's not been their experience. And our brains typically will follow. I don't know if anyone's familiar with the book, The Body Keeps the Score, or with that kind of line of understanding the connections between trauma and the body. But it is highly recommended if you want to dig deep or dive deep. Having a support person, again, can feel kind of cliche, but if we think about things through the context of being in a potentially invalidating environment, having a person who's our unconditional support, unconditional positive regard and validation can buffer a lot of the impact of challenging or even just overwhelming interactions. And then one of my favorite activities or kind of ways to feel a sense of personal safety is through containment. So we know life with a chronic illness or condition can be all-consuming. It's a full-time job in many, many cases. And one of the ways to kind of maintain that feeling of security and safety is, especially around stressful interactions with healthcare, is to ensure that the experience is just that. This is an interaction. The feelings are here, and I'm going to find a way to contain it. By maybe planning something immediately before or after the appointment, something pleasurable, something, grounding and distracting. Giving ourselves 30 minutes to worry about the session, 30 minutes of prep time before, and 30 minutes to debrief, feel, plan afterwards, and then we've contained it. We'll put it on the shelf, not to avoid it, but to pick it up again when the emotions are less, when the intensity is less, when we have that capacity, so that we don't ultimately fall into the cycle of avoiding because it's too big and worse outcomes. And then trustworthiness. So like we mentioned, on the provider end, the idea of trauma-informed care comes from transparency, boundaries, and effective communication. Through provider training, that really encompasses what we are taught patient-centered communication looks like. But as patients, we are also obviously key players in patient-centered communication. So through a trauma-informed lens, how can we also support this approach? It can be very challenging to communicate complex needs, especially once you become anxious about it. It feels like it's easy to shut down, and it's hard to organize our thoughts. So there's a specific strategy that I hope won't sound too simplistic or to minimize how challenging this can be, but that I have found works for a lot of patients, even just organizing their thoughts, feeling a sense of empowerment and structure around their communication with providers. And that is, and you may be familiar with it, the Dear Man approach, and you can Google that and find a million diagrams and worksheets because it is really well validated and supported. So I often encourage people to kind of plan what they want to communicate using these worksheets even, to think through their communication, their strategies, making sure their needs are heard and that they get what they need. Even if they just think through this framework, it tends to be really helpful. Also, even kind of thinking of it as a preventative strategy, I use it a lot to help teach children and adolescents how to effectively advocate for themselves in a way that preserves positive provider-patient relationships when they're younger, before, they're having more opportunities to potentially experience challenging ones. And I find it not only teaches that skill, but provides a sense of empowerment of, I am engaged in my own medical care. This is not happening to me, it's happening with me. And that is exactly what we need patients to experience and feel to buffer against the overwhelmingly potentially traumatic experiences and ultimately then their mental health outcomes. So then the third tenet that was noted is choice. So as many of you know, so much of life with chronic illness, chronic pain, chronic conditions is out of our control. That alone, that uncertainty and perceived sense of loss of control can be traumatic and highly stressful. So we're almost forced, or we want to at least, lean in to all the ways, all the contexts that we do have choice. And I think this can be hard sometimes because we, don't want to be perceived as difficult. We, forget that we don't just have to go with the flow. So that we, if I don't say anything, if I don't, give, a preference or state this, then that I'll for sure get what I really need. But that is ultimately not beneficial to, protecting yourself, preserving your autonomy in the medical system. So thinking through all the little choices. I'd like to complete this via telehealth. Would that be an option? Can I do a PICC line? I'm exhausted by pokes at this point. I know it's more work. I'd like to ask for that. I'd like to advocate for that. So even in the little small ways, can I dim the lights before the provider comes in? Stop and ask yourself what preferences you have, what you need. And, increasingly, and especially in supportive environments, feeling empowered to maintain that autonomy and maintain those elements of choice. And then collaboration. So, and I'm trying to be cognizant of time, but I think we're still on track for some time, for even time for questions.
Yes.
Okay, so I didn't look at what time exactly we started, so
It's okay, I got you.
Okay, perfect. So the study I mentioned earlier when we talked about that, 90% of EDS patients have had negative provider-clinician encounters. That study also found that 79% of those patients reported recognizing that after that encounter, it really changed the way they interacted, how they interfaced with providers, kind of in negative ways. And certainly that is understandable, but we can also see how that can play a role just in that vicious cycle that we talked about. So, it may be just even our awareness of how we're leaving an encounter and walking into the next one, how that could potentially impact future collaborations, the quality of that patient-centered communication. Because ultimately the goal of collaboration is to find a common ground, to kind of maintain attunement to each other's perspectives, and to move forward with an agreement and a shared plan. So again, the burden of maintaining that kind of communication is on the provider. But if we're aware of also how we present and how we're walking in, especially, if we're coming out of one interaction jaded, frustrated, recentering, being aware, I'm safe, my body's safe. If I can't trust this provider yet, that's okay. I can trust myself. This is a blank slate, and I'm going to engage in a way that supports collaboration, which again is so much easier said than done, but 90%, I think, of that challenge is knowing and being aware of our potential to expect negative, and that then in turn impact the collaboration. It's one of the things I always tell my neurosurgeons when they're maybe frustrated, or they're like, they don't believe me. They don't think, this isn't a neurosurgical issue. And they're frustrated and they know that the patient feels dismissed. I tell them, you know what, you are the expert on medicine, on neurosurgery. They are the expert on their body. This may not be a neurosurgical issue, but how can we engage in those conversations that supports that you do still see them as the expert on their body? And so I have that conversation with them a lot, and they're very receptive. They're wonderful. But I think it's, the flip side is true. As patients, we are the experts on our bodies, and as much as we can kind of engage in collaborations through the lens of they are the experts on medicine, I think that supports trauma-informed care and approach to that collaboration. So then the last tenet was empowerment. And I think collectively, all of these kind of considerations, actionable ways to engage in healthcare to protect ourselves from the stress of it, even if it never rises to a level of trauma, is kind of maintaining our active participation as the most important member of our healthcare team. It can be so easy to kind of withdraw, to give up, like was mentioned in the previous talk, to wait until things get really bad to seek out the care that we need, ultimately to avoid the potential for it not to work, or for it not to go well, for me not to be heard again. But to the extent we can stay engaged and commit to, even just through communication, deciding that, this is going to happen with me, not to me, is really the best way to ensure good mental and physical health outcomes, and that we are kind of connected and engaged with providers in that patient-centered communication, doing our part through kind of this trauma-informed lens approach. So that is what I've got for you today. It does feel very odd not being able to see the group I'm talking to, but I am thankful y'all are there, and hope that that has been helpful in some capacity. I'm happy to share more resources if that can be helpful, and would love to answer any questions that you have and that we have time for.
Thank you. I know it is kind of weird to not see anyone. I'm gonna see if I can. Does anyone have any questions? I'm gonna see if the microphone will work if you have a question. Getting tired. um, can you talk a little bit more about some of those worksheets that you had? I know the Dear Man, that was great. Actually, I'm planning on using that when I have a difficult conversation. But is there any other really useful tools that maybe people can download? Or
Yes. So, Dear Man is part of a broader kind of set of skills that they came from dialectical behavior therapy, so DBT skills, which is actually also the theoretical model that invalidating environments came from. And so I have found that a lot of DBT skills worksheets and approaches are a really good fit for chronic illness, chronic pain patients, for kind of buffering against some of these issues and considerations. So specifically, the Dear Man, they have other tools for effective communication or interpersonal effectiveness that I think apply to advocacy beautifully. Their distress tolerance worksheets, and you can Google this and they're free, but distress tolerance, interpersonal effectiveness, and they have a lot of mindfulness and grounding strategies and techniques. Those I think are the first kind of group of resources I'd point you towards. Like I said, DBT skills. If you Google that, you will find so many free resources that I think are really, really powerful.
Okay. Last, yes. Okay. Let me see if I can run it over.
Can you hear me?
Yes.
Hi, this is Sunil Patel. I'm a neurosurgeon at MUSC. And you work with the neurosurgery group in the Children's Hospital at UAB. Do they
Yes.
treat EDS patients?
Yes, we do. We see mostly insofar as it overlaps with Chiari malformation. So we have we're really the only pediatric neurosurgery group in the state. So I mean, several times a week we have Chiari patients doing, decompressions and things, and we follow for their neurosurgical care, and many of them have comorbid EDS.
Birmingham is very boring. Do you like Charleston, South Carolina?
I'm actually from South Carolina.
Oh, you are lost. You need to come home.
What neurosurgery group would want a psychologist tagging along anywhere other than here? Maybe one day. But yes, and I also I've worked with other patient populations, pediatric patient populations with high rates of EDS, and I actually have EDS myself, and a lot of my family is diagnosed with EDS. So a lot of exposure in different contexts, both as the provider and the patient.
Oh, that's awesome. Thank you so much, Dr. McRae. We really appreciate it.
And thank y'all so much. I hope the meeting has gone wonderfully, and I am thankful to have been a small part of it.
Awesome. Thank you.